I'm Dwayne Schultes. Welcome to this Vital Health podcast. While new advanced cancer treatments have improved survival rates, the lack of a coordinated and fully implemented strategy in the EU, such as the previous Commission's Beating Cancer plan, put innovative cancer breakthroughs at risk. What should the European Commission do over the next 5 years to ensure their previous commitments to cancer are met? To answer this question and many more questions, I'm pleased to be joined by two excellent speakers. Andreas Charalambous, the past president of the European Cancer Organization and professor of oncology and palliative nursing care at Cyprus University of Technology. Andreas, thank you for joining us. How are you doing, sir?
Thank you, Dwayne. It's a great pleasure to be here, and thank you so much for the invitation. Looking forward to our discussion on this very, very important topic when it comes to beating cancer within the EU.
Me as well. And I'm also joined by Lieven Annemans, professor of health economics at Ghent University and the past president of ISPOR. He's published over 300 peer-reviewed papers and 4 books on health economics. Lieven, it's always great to see you. How are you doing, sir?
Thank you very much. I'm doing very well and also looking forward to this discussion.
So I'm going to open up really helicopter high view here. Does the EU still require centralized efforts to address cancer like the Beating Cancer plan? Andreas, I'll start with you. Do we need a centralized plan?
Most certainly, Dwayne. I believe, in my opinion, that we still need it. For example, the cancer mission and the EU Beating Cancer plan, it's out there, but it's not fully deployed in every country and in every sense in the EU. So there is still a long way to go ahead. Cancer, it cannot be beaten in 4 or 5 years or even 7 years, which is the time frame for the EU Beating Cancer plan. So we need to be strengthening the efforts over longer times, a period of times, but also we do need that centralized and coordinated efforts, because the complexity of cancer, it's in such a level that we cannot tackle it on our own. We need this collective effort, both from a clinical perspective, from a policy perspective, from a research perspective, from a financial perspective, in order to be able to even stand a chance. And we are happy to see that the EU is continuing to introduce these centralized approaches. Take, for example, the ECHOS project, which envisions to put in place national cancer mission hubs, which will be acting on a national level, but altogether will be like a coordinated chain of hubs in order to decide, envision and execute different actions when it comes to battling cancer. So yes, in short, I do feel that we do need these centralized efforts from the EU perspective.
Lieven, picking up on that, if we look at cancer specifically, why would Europe require a specific cancer plan? What makes it so challenging from a policy perspective?
Well, first of all, cancer is still a major cause of lost life years and of disability, clearly. And there is a lot of consequences of this disease for the victims, but for the family and so on. So that's clear that we need a plan, and I agree with Andreas, we need a plan. But ideally, a plan needs to be fit into a kind of a plan, do, check, act loop. And what I'm missing a little bit at the European level is that there is a plan, there are some great initiatives, but then we also have to check, are we making progress in what we were willing to do? And can we then change the plans if needed in order to do better than what we are currently doing? And that's something that I'm missing a little bit. And I think, and I'm convinced that at the European level, this is something that we can do. And it is within the competences of the European Commission to indeed not only plan, but then also doing the checking and then also revising the plans.
Isn't part of the problem as well that when you look at cancer as opposed to cardiovascular disease, these are very small indications. If you look at B-cell lymphoma, you're talking 15, 20,000 Europeans maximum at any one time who are going to be under treatment. And because of that, there's a cost issue there too. Sometimes these can have impacts on budget. You're both nodding. Lieven, I'll come to you. What do you reckon?
When it's about cost, then you come to the health economists. And it's indeed true that in terms of return on investment, if you spend a lot of efforts on a rather small indication, then it's much more difficult to get a decent return on investment because you don't have your economies of scale, so to say. But in my view, and Andreas, correct me if I'm wrong, even with the rare cancers, there are many common aspects with other types of cancers, how we have to prevent it, how we have to earlier identify those cancers, how we have to treat them with the best possible technologies. So I think the rarity should not be an argument against. Rather, it should be also an argument pro-investing, because if you are unlucky to have this rare cancer, we have to do something for you as a patient. We shouldn't leave no one behind. And so we have to look at the totality of all these types of cancers and make sure they all fit in that plan, and preferably in this plan, do, check, act cycle.
Cancer affects literally every aspect of a person's life, and this also translates into policy. For example, we cannot develop one policy and tackle cancer. It's impossible. When it's picked up by politicians, it's overwhelming. And we do know that politicians, they often want short wins. And perhaps the greatest investment in cancer is prevention and early detection. But the oxymoron here is that the least of the budget goes to these aspects of treating cancer.
Isn't it also a situation where it's easier to propose a program and pass a law as opposed to then following up politically? There's less political cost once you put it in, as opposed to, I don't want to be cynical, but sometimes, saying you're doing something, but then following up is often more challenging from a political reality.
Yeah, of course, but following up should be part of the plan, of course. So part of the plan is, what measures are you going to take to follow up what you are intending to do, and how to measure it, and how to improve them, even your plans in function of what you're observing. That should be always an integral part of a plan. What also I'm missing a little bit is the involvement of patients. It's improved compared to 10 years ago. But in fact, the rule should always be nothing about the patients without the patients.
If we're trying to improve these programs, you, Lieven, on March 26, you participated in a PricewaterhouseCoopers policy session called Future-Proofing the EU Healthcare Systems. You said there were two critical factors highlighted, and one of those is demographic evolution, which you called a ticking time bomb, and unequal access. How do these in particular impact in the indications of cancer specifically?
That ticking time bomb, that's obvious. We all get older, more and more 65 plus, and we know that many cancers, the incidence of those cancers are age dependent. So the older we become, on average, the more cancers automatically there will be. And here I want to come back to what Andreas said. The only way to deal with that ticking time bomb is to intervene early, because everybody's talking about promoting lifestyle, healthy nutrition, exercise, smoking cessation, and moderate alcohol use, etc. Everybody's talking about it, but few countries are really taking that seriously, in the sense of, we are going to make our population a healthy population. There are so many cancers that can be avoided by better lifestyle. In most countries, we underinvest in health promotion. And in my view, that's the key to deal with that ticking demographic time bomb. And that second point, that's also something that is I'm very sensitive for, that is the inequalities. We claim in Europe that our health systems are based on solidarity, and that there is universal access to good healthcare, and the reality is that we are far away from that. And we see not only differences between European countries, sometimes with, in absolute terms, 20-30% difference in survival of a cancer between countries, in absolute terms, they're not relative. And then also within countries, we also see that those who are in the lowest income categories have clearly poorer survival than the others.
We know that since January 1st of 2020, only 19% of products that have been approved by the European Medicines Agency, new medicine, only 40 of those are available in Greece, 19% of the 221. What is it about Greece that makes it such a challenge, and how do you think you can improve that?
I think it relates very much to the commitment, the national commitment to, for example, the EU beating cancer plan. Of course, I can easily say, yes, it's an excellent plan and I will implement it. But you can have a national cancer plan, but no budget. So you cannot change, you cannot tackle, you just do what you continue to do as a routine. And this lies heavily on the shoulders of politicians to implement, because implementing the cancer plan is the trickiest part. We need to have the data to see how good we are doing and what needs to be further changed. So I do think that the access to those critical medicines, it depends heavily on the financial policy that a state implements. What is the responsibility of industry in this? Because we do know that industry plays a vital role in policy formation and implementation. And we have seen that on a European and a national level so many times. So there needs to be a coordinated effort. And this is also where Lieven's point earlier on about consumers or users' engagement in the process, because they need to become part of the system in terms of providing the experiences, but also the data from a patient and user perspective in order to shape the policies as best as possible and make those policies as personalized as possible.
So we've heard from you some of the challenges that we have in certain countries. Lieven, you've mentioned there's some countries doing some things that are good. Do you have some specific examples? I mean, I know the Germans had a cancer plan. Do you have some other examples of countries that are implementing at the member state level effectively?
Yeah, definitely. First of all, it's already at the input. How much does a country want to spend on cancer? And there we see from recent European data that some countries only spend 50 euros per capita on cancer, and others up to 300 euros per capita. So that's 6 times more, and those numbers are already taking into account the purchasing power parity. So it's already correcting for differences in purchase power. So that's already a start. How much money are you willing to invest in cancer? The second is, what are you doing then with that money? What we see is that in some countries, they are on purpose trying to slow down the adoption process for innovative medicines. If they find it too expensive, then they have to tell so, and then we have to find a way to assess what do we mean by too expensive. In my view, the price is only just one element. We really have to look at the value and so the cost effectiveness of a treatment. But just slowing it down because of the costs, I call that cost myopic. You're only focused on the cost. You need to focus on the entire picture, and if then you still find it too expensive, then you have to tell that company, and preferably a while before the company submits for reimbursement, you have to sit together and say, well, we believe that your product is not value for money, what are you going to do about it? That would be the right approach, and that's what we see in some countries where they have early dialogues with the companies. What we also see, some countries have a higher willingness to pay for cancer. What I mean by that is that if you can gain what we call an equality adjusted life year in a cancer patient, it is worth more than winning a quality adjusted life year in another disease like arthritis. And you could talk about what is fair, what is not fair, but those countries who express a higher willingness to pay for cancer treatments, they do that because they are convinced that cancer means a lot of suffering, and therefore because the medical need is so high, they are willing to pay more. And that's an engagement that is something that I like to see, because then explicitly you say, we want to do something about cancer and we have a budget allocated to do that, and we use that budget to have hopefully cost-effective treatments.
That's a really interesting point, particularly related to the virulence and the impact of cancer. What we see is a huge dispersion between access and availability, as you've just mentioned, this 6x different investment level. And Andreas, coming back to you as well, there seems to be something of an inertia to try to put policies in place to get actual finite results. We've heard that there's sort of a hostility by some HTAs and politicians about the cost. What is it about this policy specifically around cancer that creates this inertia politically?
I would say that there's many reasons why there is this inertia, because cancer has always been a high cost, high risk investment. So as I mentioned earlier, politicians, they're aiming for short time wins that will make their profile look better, but the real value when it comes to cancer, in order to be able to tackle it over longer times of periods, it needs high investment early on when there is no actual cancer in place. You have to be preventive and proactive, and all these strategies and campaigns, they need quite a significant restructuring. Policymaking so far has been mainly reactive. We haven't seen any proactive action, at least not to the level that it is desired. Patients are a stakeholder, but we rarely acknowledge them as one. We simply say this will be the user of this policy and so on. But we need to have a mind shifting and cultural shifting approach if we want to change this policy inertia. And we need to take risks, because if you have a patient who gets cancer, it costs 10 times more to treat that patient than to prevent that patient from getting cancer. So if it's all about the money, then the data are there. And take, for example, the lung cancer screening. And I was very happy to see that only recently Australia and Germany, they choose to introduce a national-wide lung cancer screening program. The evidence are clearly, when you do have high-risk populations at risk for lung cancer, if you do low-dose CT to these populations, the gains from these screening programs it's huge.
It's typically what Andreas is giving as an example. In the policy documents, everybody's talking about we have to do the best for our patients and for the health of the population, etc. But then when you talk face-to-face to policymakers, the first question is, what is this going to cost? So they are focused on the cost. The same for lung cancer screening. What Andreas says is correct. And there are already studies showing that with the low-dose CT, that this is also much safer and also cost-effective. But yet, what then comes on the table are the issues. Yes, but what with incidental findings? What will you do with that? And what with this and what with that? And so on. So I have sometimes the impression that they are trying to find problems for every solution rather than to find solutions for every problem. And as long as that mentality is there, then it will be difficult to make progress. And the only way that this can be done, in my view again, is to compare countries with each other and confront them with the comparison and say, well, if they can do this, why can't you do it? So hopefully to have the champions that can then inspire the other ones to follow based on the data that compare them with each other.
Yeah, but the challenge for that, Lieven, is, as you know, when this has been tried at the country level, it was tried in the UK, the doctors started screaming bloody murder and jumping up and down and threatening to eat worms. They got absolutely furious because putting that accountability in the system, particularly in a socialized public healthcare system where the doctors, for better or for worse, sometimes are political actors, this becomes very, very difficult. How do you get around the sort of politics then to actually implement something like that?
I prefer that comparisons between countries, of course, and within a country, comparisons between regions, but we should not go to that level that you compare the performance of individual doctors with each other, because that's very difficult, by the way, also to correct for the case mix. I have a little bit a problem with those who are comparing the quality of hospitals with each other if you are not able to correct for the differences between those hospitals. But comparing regions with each other, with all the issues that there are, and also comparing countries with each other, for me, it's not to blame somebody, but rather to inspire them, to show them, look, it can also be done better.
Well, picking up on that, how much authority do you feel should be centralized at the EU? Historically, healthcare has been a member state competence. How much then should be distributed down to the member state? What's your opinion on that?
Yeah, the Lisbon Treaty is very clear on that. So the European Union must respect the responsibilities of the countries when it's about health. It's a member state competence and responsibility. But a high level of human health protection shall be ensured, I'm reading it here, in the definition and implementation of all EU policies. So a high level of human health protection shall be ensured. That's a European responsibility to ensure that health protection. What is good about the attitude of the Commission in the last, let's say, 5 to 10 years is that they have tried to come up with, indeed, country comparisons, individual country profiles, how are these individual countries doing, and then they're asking permission to visit that country and to talk about the profile and to ask the country, what are you planning to do about it? So the European Commission is trying to play a more facilitating role, kind of cross-fertilization role, in order to encourage the countries to do better, while still respecting the member state competence.
Decision making is on an EU level. But on the other hand, when we come to workforce, then it's a member state competence and requirement. And, there is no health without workforce, because the workforce is the backbone of any healthcare system in EU and anywhere else. Many times, we forget that the health managers, which are not clinical professionals, they're part of the system. They're part of implementing not hands-on care, but they're part of the process.
We know that in general there is an issue of what we call then digital health literacy, not only among citizens, but also among health professionals, indeed. And indeed, that's a challenge with AI, because with AI we are focusing on the AI technology, but we are less focusing on those who will have to work with it and how it will change the processes and the way that they work. And in many AI applications, we see that the workforce that is supposed to work with it, because it's always collective intelligence, human intelligence and artificial intelligence working together, but the human intelligence is not prepared to work together with the artificial intelligence. And if they're not prepared, they will do the wrong things with it. We need more is this kind of a quality label for AI applications. So like we have in many countries for nutrition, a label A, B, C, D, E, and that for these digital applications, there should be something similar that as a user, as a health professional, you can at least see, based on decent assessments, of course, what is the quality level of that application. And having said this, we should never forget that we are humans, so it should not become over-digitalized either. There should still be the human contact, of course. So the hybrid models are better in the sense that there is still physical contact between the patient and the clinician. Digital tools are not going to lead to better quality of life, because there will be more loneliness and other issues related to the lack of real human contact.
No, right now AI is just being implemented as a platform technology, and it's proprietary, and there's lock-in. So there's going to be tons of challenges with AI, compounded by the fact that Europe's investment in AI is 1/10 of what we're seeing in the US and China right now. It's becoming a real competitive disadvantage for the European infrastructure. It's a real problem. I'd like to switch gears here a little bit and look at just one of the final questions around financing and going back to this challenge of cancer requiring the investment. If we look at what just happened with Germany regarding the last election and the compromise to get a political party established and a compromise solution basically to get a prime minister elected, they've essentially issued debt. Now, this was supposed to have been issued German bonds. These bonds were supposed to have been issued to essentially support NATO. That was the overt goal, at least that's what they said. But when you actually read the legislation, a lot of it's going into infrastructure and social spending internally. This is essentially acting as a de facto Eurobond within the state of Germany. essentially what the Germans have done is used NATO and some of the pressure that's been put on internationally about the situation in Ukraine to issue debt that's going to be paying for infrastructure. I mean, should Europe get serious about issuing or allowing countries to issue more finance to invest? Is this something that should be taken seriously? I mean, Germany's doing it now. Should other countries be looking at this as a solution? Lieven, you're smiling. I'll go to you first.
I teach health economics to medical students, and in my classes I cite always a study where they looked at the impact of spending €1 in health. What is the impact of that on society, not only in the short term but also in the long term? And spending €1 on defense, what is then the impact in the long run? And we call it in economics the multiplier effect. So any euro that you spend, what is the multiplier of that euro? Well, health is performing much better than defense with that regard. So I think we should invest more in health. And I always have troubles with this 5% now. We have to go for 5%. If we would have been creatures with 6 fingers, I'm pretty sure it would have become 6%.
6%?
So, yeah, I think it's not very well substantiated in my view. But anyway, I'm not a defense specialist, but a health specialist. 1% most wealthy people in the European Union, they have 25% of the wealth of the European Union. So 1% owns 25%. Maybe they could contribute with a special health contribution.
If you gentlemen had a magic wand or the opportunity to implement one policy right now in the Commission in the next 6 months that would tangibly impact cancer treatment and cancer outcomes in the EU, what do you recommend that to be? Andreas, I'll start with you. If you had one implementation plan to help cancer specifically, what would you like that to be?
I would like to do 2 things. I would like to see...
We'll give you 2, Andrea. We'll give you 2.
Okay. Well, the first one will be to have a much more data-driven policy across the EU, but also on a member state level. And the other one will be on prevention.
Lieven, same question to you. What would you like to see implemented in the next 6 months?
Well, what we know is that the biggest impact can be derived from tackling the social determinants and the commercial determinants. With commercial determinants, we mean all those companies who produce products that are not good for our health, and they are not sufficiently, let's say, countered by our policies. And it has been shown that if we invest in tackling the social economic determinants and the commercial determinants, that this will have the biggest impact. But there is one caveat: that will have the biggest impact, but not next year. It will have the biggest impact in 10 to 20 years from now. But that's a reason more to start tomorrow with that, because if we're always postponing it because we say, oh yeah, but it will only bring benefits in a long term, so why should we do it? For me, it's just the reason why we should do it now in order to have those long-term benefits as soon as possible. And ideally, ministers of health and maybe ministers in general should have also a long-term responsibility for the next generations and not just for the next election, and should be made accountable for that.
Moving the needle in cancer care. Andreas Charalambous and Lieven Annemans, thank you very much. Gentlemen, it's been a pleasure. Thank you.
Thank you.
Thank you, Dwayne. It was a pleasure as well.
This Vital Health podcast was made possible with the support of Merck, Sharp & Dahm. Our project director is Caden Drake. The Vital Health podcast is a production of Vital Transformation LLC, copyright 2025.